This is my title. I'm an associate professor in Kansas. I direct the hematology clinics and the leukemia clinic in terms of structure. My focus is on myeloid neoplasms in general. So the idea for this talk has evolved, and we decided to emphasize on true hematological changes in the last year that we're practicing immediately in clinic. So everything I'm going to talk about today are things that are currently standard of care or have changed the standard of care within the last year. So that's why we're going to be covering multiple topics, but mostly on the highlights and things we're going to go and do on Monday, basically. So these are the diseases we're going to be touching on today, and hopefully it'll be a soil for more discussions after this talk. So for chronic myeloid leukemia, it's a chronic malignancy that has become an example for success in targeted therapy. We have had multiple lines of therapy. Ponatinib specifically is a unique third-line therapy for patients with CML that has been vetted and has been studied extensively and successfully. And it is our potent drug to go to in patients who are relapsed refractory after tyrosine kinase inhibitor therapy. The data for the ponatinib has been studied with a 45 milligram dose after failure of multiple TKIs and has shown great activity, but also cardiovascular toxicity, anywhere in the range of 15 to 30% peripheral arterial disease, which remains a stigma or a concern treating patients with ponatinib. So given that background, this study was designed as a randomized phase 2 study, the OPTIC study, and was presented multiple times, most recently in ASCO 2021, in which patients who are eligible for ponatinib would be randomized to different starting doses, either 45 milligrams daily, 30, or 15, with a planned mandatory dose reduction based on response. Patients who respond with the milestone defined as 1% on the PCR or a complete radiologic remission, they would mandatorily be reduced to lower doses down to 15 milligrams daily to maintain them. The goal of this is to maintain efficacy, but also risk mitigation and reduce toxicity, and to pick which dosing level should be using going forward. So that was the goal on this study. The patients selected were patients who were resistant or refractory to at least 2 lines of therapy or have resistant mutations. So the study has a clear winner. So again, these are the results from that study without going in more details. But the dosing schedule of 45 milligrams once a day was the winning arm at every single endpoint. So, and also at every single time point. So patients on 45 milligrams once a day with planned dose reductions had higher responses and also higher efficacy. And then, as you notice on the lower panel slide, the approach of dose reduction did not compromise results. So patients who started with 45 milligrams daily and then were reduced to 15 milligrams daily, most of them maintained their deep responses. So this was not at a risk of loss of response. And based on, so again, that was the highlight of that study. Now, did that translate into improved cardiovascular outcomes? Yes, it did. So as you notice on the right side slide, that patients with the higher dosing, there was higher risks of cardiovascular events. The risk is actually dose dependent. So you can see the changing in severity of the events based on the dosing level. But the magnitude of difference is actually significantly blunted. So I can't see the numbers straight, but the cardiovascular outcomes is about 4% in the 45 milligrams going down to 15. And that's historically comparable to 15 to 30% on the phase 2 in the pivotal study. So this approach is truly successful at risk mitigation, and maybe this is the dosing schedule we should be using for patients who are eligible for ponatinib. Now, again, we're waiting for the final results, but these results are pretty compelling for that data. And this was the conclusion of the authors, is that this approach has been associated with the optimum benefit to risk ratio is to start with 45 and just reduce to 15 upon success, which is a standard of care for our patients. And this was a role model for other TKIs. There's many studies with other drugs now trying to adopt the same approach. The new kid in the block, the new approval that we're all excited about, is Assiminib. So Assiminib is also an active targeted CML therapy that binds ABL directly. So it's a direct ABL inhibitor or a STAMP inhibitor. It binds the myristoyl domain that is far from the ATP binding domain. So all the TKIs we use right now bind ABL at the ATP binding site. So they all have to conform into that domain. And that's why resistance is often not drug specific. Patients who are resistant to one drug might be resistant to multiple drugs. Assiminib is uniquely designed to bind at a different domain, which might offer us different efficacy and different side effect profile. So the study also included patients who are resistant or refractory to 2 lines of therapy. And the comparator arm was bosutinib. Now, bosutinib, there's a lot to say about that choice as a comparator, since bosutinib was actually not approved in a setting of multi-drug resistant or third-line setting, but that was the comparator arm on that study. And the randomization was 2-to-1 to Assiminib. Assiminib was the clear winner. So patients on Assiminib have achieved a faster response and a deeper response in a larger proportion of patients, which was declared the winner on this arm. And this resulted in an FDA approval in October 2021 for CML. There are multiple indications, but the chronic phase CML dosing is 40 milligrams twice a day or 80 milligrams once a day. That was driven from a different study. This is a medicine that you have to take on an empty stomach. So the 80 milligrams once a day is definitely more convenient to patients. The indication is after failure of 2 lines of therapy. It's also approved in patients with CML with T315I mutation, but a much higher dose. It is currently in studies in first-line setting. So hopefully this will be another option that we can use early on in our patients. And this is a medication that is already in use right now, and we've had many success stories with it already. So this is an exciting year for CML. I'm going to move on to polycythemia vera. So polycythemia vera is a chronic myeloproliferative neoplasm in which patients manifest with excessive blood production and increased risk of thrombosis and bleeding. This is an algorithm that I adopt in patients' care, in which patients who require therapy, usually phlebotomy and aspirin is a standard of care, and then hydroxyurea historically has been the drug that's most commonly used in these patients. Interferon were always on those guidelines, but they were really never picked up as a therapeutic option for patients. It's the exact opposite in my practice. Almost everybody's on interferon with, occasionally you get some hydrias every now and then. Interferons have a lot of advantages and benefits, and this has been published and validated by multiple groups. And then ruxolitinib is approved for second-line setting after hydroxyurea failure. So these are the drugs that we've had and we've maneuvered with over time. Now, the new medication that is also going to change this discussion is Besremi, or roping interferon alpha-2b. So, and this was approved late 2021. So this is a very long-acting pegylated interferon. The label will allow it to be dosed every other week. For the ones who use interferon, the shorter the interferon that you use, the more side effects you will have. The longer the interferon use, the likely more safety profile you will have. So this medication, this formulation, has the longest half-life and the least side effects. And now it's approved for first-line therapy for polycythemia vera. I think this is going to be a new discussion with patients because now you actually have an FDA-approved interferon in the first-line setting that is proven to be of benefit. Now, this benefit came from the PROUD-PV study. This study is now at least 6 years old. It was done in Europe. It was not publicized much in the US. It actually was not active in the US. So patients with treatment naive or treatment light, basically under 3 years of therapy, were randomized to Hydrea versus roping interferon. And the primary endpoint was at 1 year with non-inferiority. So as you notice on the, I think, black curve or green, hydroxyurea works quickly, and patients feel good on it, and it seems to peak at a certain level and just plateaus over there. And with long-term therapy with Hydrea, you've all seen the hydroxyurea side effects and intolerance. This is known that 30% of patients cannot remain on Hydrea, even if they're responding, because of side effects. So the hydroxyurea curve goes down with time. The interferon is slower to act, but it's more surely active. And at the 1 year mark, it is non-inferior. On long-term follow-up, it's actually superior in clinical responses. So this data was convincing enough. And Ropig was approved in Europe for now a few years and was approved in the US this year for polycythemia vera. In addition, for people who monitor the JAK2 allele burden, which is a molecular test of the disease burden itself, there's definite superiority with interferon compared to hydroxyurea in terms of the frequency of response and the depth of response. So that's one more option that we use for patients with polycythemia vera. Moving on to myelofibrosis, which is the higher end or higher risk disease in myeloproliferative neoplasms, we adopt a risk adaptive therapy. So there's multiple prognostic models, whichever one you prefer. The DIPS Plus is my preferred clinical prognostic score. Patients with higher risk disease receive therapy with a JAK inhibitor and a transplant or both. And patients who do not fit the label, they get palliative therapy or supportive therapy or JAK inhibitor therapy alone or just symptomatic therapy. So this is our standard of care therapy for myelofibrosis as we speak. To make it a little bit more colorful, so patients with high-risk myelofibrosis, first-line therapy is ruxolitinib or fedratinib now, and a transplant, if they're eligible, or both. Now, there's been a substantial number of studies for combinations. This started as in patients with suboptimum response. So you're on ruxolitinib, you're doing well, not well enough. What can you do? You add a drug, a booster, a supplementary therapy that improves your response. There's been many drugs in that sense. Persaclisib is a PI3K delta inhibitor that I worked on. There's also the BET inhibitors and navitoclax also have been studied in this setting. Those studies were all successful. This resulted in a wave of first-line studies now that are randomizing patients to ruxolitinib versus ruxolitinib combinations. There's many large phase 3 studies going on right now trying to redefine what is the standard of care now. So that's being investigated substantially. So that's happening at the forefront of MF. Now, beyond JAK inhibitor failure, so if you look at the right side of the graph, pacritinib is a JAK inhibitor that is specifically JAK2 inhibitor that does not cause cytopenias. And it has completed multiple studies, and we are expecting an FDA approval within the month of that. So this is a medication you might want to familiarize yourself with because soon it might be an option for patients who don't benefit from JAK inhibitor therapy or have contraindications. Momelotinib has gone through multiple pivotal studies and also is expecting an FDA approval this year. So hopefully by the end of this year, by the time of the next conference, we're going to have 4 JAK inhibitors. We're going to have this discussion which one to use and which one to start with and what's the best combination and all of that. So hopefully the discussion for myelofibrosis will be more colorful next year once many of those drugs are approved. So this is an example of the studies we just discussed. So the LIMBAR 313 and LIMBAR 304 are the parsaclisib program. Both are being investigated in global phase 3 studies. The 313 is ruxolitinib versus combo in first-line setting. And the 304 is ruxolitinib therapy suboptimum response, and you randomize patients to an add-on therapy. Both studies are going on nationally. There's other examples too. So I'm going to move on to mastocytosis, a disease we almost never heard about, but now we really need to know a lot about. So Mastocytosis is another myeloproliferative neoplasm. It's a cancer of mast cells. Mast cells are active cells that produce cytokines. Patients with mast cell cancers are very symptomatic. They have significant morbidity with their disease. There has been no therapies, and subsequently, we really don't hear about it much, but this is about to change. So these are the diagnostic criteria for mastocytosis. It's actually cumbersome to make a diagnosis. You need major criteria, minor criteria, bone marrow biopsy, multi-organ biopsies. You need to meet all those criteria. Special testing, the KIT mutation is not really easy to get, even in tertiary centers. It's almost always a send-out. But then once you make a diagnosis of mastocytosis, then we reclassify this. Is it indolent, or is it aggressive, or advanced? Advanced mastocytosis includes 3 diseases: aggressive mastocytosis, mast cell leukemia, and mast cell with associated hematologic neoplasms. As a group, this is a serious malignancy. The life expectancy is anywhere between 6 months and 2 years for those patients. There has been no therapy, and they're really only supportive care, and chemo is and they're refractory to chemo. We transplant who we can. So again, there has been no therapies for these patients, and they are both facing poor prognosis and poor quality of life. There are B and C findings. B findings are mostly consistent with disease bulk, while C findings are associated with organ failures. So you can think of this as an MGUS, smoldering myeloma, and a multiple myeloma in that description, basically. So if you have C findings, you have symptomatic malignancy with organ failure, just like a symptomatic multiple myeloma in that sense. So if patients have an aggressive or advanced mastocytosis, midostaurin, Rydapt, was the first drug investigated in the study. It was a success. So patients with midostaurin actually had objective responses around 20%, and they've had clinical responses around 60%. And this resulted in FDA approval in this very rare disease, and this has been approved for the last 5 years. It does have significant side effects and QTc prolongation risk, but it remained an active drug until avapritinib got studied. So avapritinib is a medication you might be more familiar with in the GI oncology. It's approved for just tumors for PDGFR inhibition. But it's also a very strong KIT inhibitor. It's actually one of the strongest, most selective KIT inhibitors. As you can see from the waterfall plot, almost everybody responds to it, objectively on response. And then for those patients with a life expectancy of 6 months to 2 years, you can look at the overall survival curves on this pivotal study. Almost 100% on the ASM, on the aggressive mastocytosis. So again, it's definitely disease modifying, and it has changed the course of the cancer for those patients. So this was also approved in last year. It's a medication we already are using in clinic, and it has certain side effects. It's also being investigated in indolent patients at a much smaller dose for symptom management only. So for the physicians involved in symptom management, this is also going to be another venue of help for patients. So the last few minutes I'm going to spend on acute leukemia. There's not going to be enough time to cover acute leukemia, no matter how much time you give me. So it's a broad disease. There's so much going on with acute leukemia. In the ABCs of leukemia is that we have to recognize who's ill early on. We have timely approach to patients. So and timely access to do all this new molecular testing, the abundance of testing that we have right now. So this is, and I'm going to provide the slides for your own reads, but again, these are the emergence in, as soon as you get acute leukemia patients, you need to complete their workup. They need their molecular profiling. Molecular profiling changes your induction therapy. If you FLT3, it changes your induction therapy. If you have core binding factors, you add Mylotarg. So this is immediately, it has changed how we practice patients. And then acute management of acute complications and emergencies, tumor lysis and differentiation syndrome. This is something we have to be all comfortable with as we treat acute leukemia. And then early and prompt bone marrow transplantation referral. So again, if there's one intervention that would improve the acute leukemia outcomes today, it will be earlier referral to transplant for patients who are upcoming. So acute leukemia was very simple until a few years ago. If you're fit, you get induction. If you're not fit, you get HMA. It was pretty easy, dichotomous. Things have changed a lot now. So there are all these drugs on the table on the right have been approved in the last few years. CPX-351 is a liposomal combination of doxorubicin and cytarabine that has been approved for patients with secondary AML and MDS-related AML, which is associated with improved survival. It's become a standard of care. Mylotarg came back again, gemtuzumab oxazomicin, for either single agent or for combinations. HMA venetoclax now is a standard of care for unfit patients and patients who refuse to, and there's so many other targeted therapy on that table. So all these things are now in our armamentarium to help patients. This is a general algorithm of how you approach patients in our clinic, and now it's not dichotomous anymore. There's many red boxes, as you can see. So we have multiple different approaches to do this. Now, the one therapy I would like to emphasize is the Vidasa with venetoclax, the VIALE study. This has been absolutely practice-changing. This is the standard of care. This year, they presented their overall survival data with the HMA venetoclax, Vidasa venetoclax has, in addition to achieving a higher rate of response rate, much earlier responses, 1 to 2 months versus 6, and also now overall survival advantage. So now this has become the standard of care. It is a cumbersome regimen to give in outpatient setting, but it's deliverable in outpatient setting. The study allowed admission for this, but we do this as outpatient. You just need to be comfortable delivering this therapy in your clinic and have hands-on experience and toxicity management and so forth. And this is just an example of what we do to try to keep patients out of the hospital for this induction. So thank you very much for your attention. And I hope this was helpful, and we're very excited about all the new tools we have to use to help our patients. Thank you very much.